this week's presenters. We have Doctors Allison Carroll and Ashley Knapp, two superstar methodologists who are both faculty in the Center for Dissemination and Implementation Science. You had the pleasure of hearing Allison present last week, and this will be your first time getting to hear the talented Ashley Knapp. Both of them are also small group leaders, so you might have had the pleasure of engaging with them in your small groups. And I'm going to turn it over to the two of them to talk and teach us about implementation strategies.
Thank you so much, Sarah. Glad to be back again with you all for this session. It's always fun to do back-to-back because I can really see how talking through determinants last week or 2 weeks ago is setting us up for implementation strategies, which is really the meat of what we're hoping to share with you about what implementation science is. So next slide, please. So we're going to start, of course, with just talking about what are strategies, defining that as a concept, and also starting to think about classifying them into different groups. We will then get into the application of how do we actually pick the strategies that we want to use and how do we report on that. We will talk about centering equity within this process of selecting implementation strategies, and then go through our community and health systems examples before diving into our discussion groups. And so our learning objectives for implementation strategies is to be able to describe a range of these D&I strategies, to then be able to evaluate and adapt strategies for different populations, settings, contexts, resources, and/or capacities. And then, of course, to understand where and how implementation strategies fit within the process of implementation, and specifically within the IRLM, the implementation research logic model that we've been working through. And with that, I will turn it over to Ashley to dive in.
Hello, implementation folks. Welcome to Strategy Week. Woo woo. All right, so I'm going to be chatting with you guys to chat about defining and classifying strategies. And oops, nope, I'm going to go backwards first. Just kidding, guys. Beep, 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 beep. All right, actually, I skipped one. So I really like this this diagram. I use it actually in some presentations that I do for just to talk about implementation science and where strategies fit. And actually within the NIH or National Institutes of Health definition of implementation research, it really does talk about or kind of focus on strategies, just like Allison said, kind of the meat of it. So the scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings. So you can see we were starting here to identify the determinants that Amy and Allison were so gracious to open our minds to. And then you'll see here, now we're going to talk about selecting and tailor strategies. And then we move on and we'll talk about that too. But again, it's kind of the meat of the implementation research. And then thanks to Dennis Lee on this one, where this comes about is back in the day, which not very much back in the day because implementation science is pretty new, but strategies were called interventions. And as if you come from the intervention world, especially the clinical intervention world, you're like, wait, we have interventions. That's really confusing. Yes, it is confusing. That's why we don't do it anymore. But if you want to think of it as an intervention, strategies as intervention, it's interventions on the system. Again, this gets really confusing between clinical intervention and implementation intervention. So I think we as a field have kind of gone away from that a little bit and really tried to focus on implementation strategy as the methodology or as the term. All right, so you have here. So what the strategies really are. So, and I would say, taking a step back, beep, beep, beep. This is a really meaty slide, but a really good one. So if you need to come back to this, I would say this is understanding strategies. This is a really good meaty slide to come back to. For sake of time, so strategies, methods, or techniques used to enhance the adoption, the implementation, the sustainment, or the scale up of a program or practice. I think what's tricky to try to remember, and again, going back to the clinical intervention versus implementation strategy, is to remember the strategies do not have a direct effect on the client patient level health outcomes. I think that's what's pretty beautiful about the implementation research logic model is you are able to put both in, so you can kind of help differentiate, but that's just kind of a friendly reminder. It's often multi-level, and the scope. So this is different kinds of strategies. So a discrete strategy is just a fancy way of saying just this single strategy. So we're going to use this single strategy, let's say reminders. You could also get more fancy with it, as you can imagine, getting into multifaceted and packaged and then blended as well as protocolized. And the blended protocol, that just means, are you looking at the individual impacts of the strategy, or are you looking at the strategy package as a whole and the impact on that? Yeah, let's see. And then what we're really targeting or trying to interact with, and I would say kind of respond to are the determinants. So what were those barriers and what were those facilitators? What are those things that were kind of getting in the way of the clinical or not clinical outcome? Oh, catching myself, of the implementation outcome that we're interested in. And how can we come up with strategies to target that? And the ultimate goal is just to achieve those implementation outcomes. And if you're thinking of the IRLM, being a real nerd, it's kind of that right, the implementation outcomes on the right. Just know it's rarely a one-to-one relationship between strategy and determinant. Sometimes there will be strategy that can map on or target multiple determinants, and then sometimes multiple determinants will map onto just one strategy. So know that it doesn't have to be a one-to-one. All right, you guys have seen this before, just kind of walking you through what these different things mean. The implementation strategies, this would be the actions we take to help others do the thing. And again, the thing being the innovation, I won't say intervention, to improve people's health. Beep, beep, beep. All right, so I've referenced this a couple times, but where does this fit on the IRLM or the implementation research logic model? This would be right here. So just kind of a little reminder, and what helps me differentiate is the kind of the clinical intervention mechanisms and the clinical outcomes. That's what we kind of typically think of. But then what we're doing is filling in the rest of these. So the determinants that we went over last week are here, and then implementation strategies live right there. And then if we want to, I won't have a lot of time to go into this, but going back to our models, theories, and frameworks. Oh my. So these draw a lot on theories. Eric, which I'll go over in just a second, actually came from theories, theoretical models, and then put in the process models, since we really focus on that in research. Oh, right. Okay, so determinant strategies and mechanisms. So just orient you guys, determinants, remember what we learned last week. These are barriers, facilitators, and then strategies, what we're learning this week. There's also been some pretty cool new research around possible mechanisms. I will say it's pretty, this literature is in its infancy, so we're still really learning a lot about it. But so just to provide an example, and I think you guys can come back to this too if you're like, oh, what is it? I need help of example of what a strategy or what a determinant would be. So let's say that there is a provider knowledge deficiency. One strategy to kind of tackle that or target that could be education. So maybe providing those folks or the providers with information or trainings. And then a possible mechanism could be, oh, this really increases their awareness. It builds up their awareness, or, oh, this really increases their knowledge. So all that to say, it's kind of fun. And in my mind, it maps onto the intervention world of independent variable, dependent variable, and then moderator, mediator, but that mechanism. So I think we're going towards that. But if that helps kind of put it into context. All right, and sorry guys, I know this is a lot and going quickly, but thanks for hanging on. And these were part of your readings. So I'm more of a big picture person. So if we're taking a step back, we're like, okay, we know strategies are important. So where are we going to start? Byron Powell, one of the 4 people in this field, really, and also a fabulous human. And so like, okay, we want to know strategies. What does the literature say? So this was a 2011 review of 205 sources. And what they found was, okay, we found 68 discrete strategies, meaning discrete meaning is just that would be one-off rather than kind of a packaged bundle. And then since 68 is a lot and our brains need categorization, put these into 6 different categories. So as you can see, those categories are here. So they'll map onto plan. So this would be to the left, gather data, build buy-in, develop relationships, educate. So this would be inform stakeholders, finance, incentive, train, kind of the funds that are there, and then 3 others. So I think, or at least how I think of it, this is just, okay, what does the literature have to say so far on how, what those strategies that are being used and how to categorize them? So then we move on in time, beep, boop, beep. As you can see, it's still Byron Powell, or at least for the ERIC, which is the Expert Recommendations for Implementing Change Project. So we had the systematic review. Now we're going to move, okay, what if I were Byron, this is what I would think. How do we get how do we get the kind of bigwigs or the experts in the field together? And if you found some of these confusing, that's okay. It is a confusing article, especially the concept mapping one. But so thinking of the ERIC, this is where folks came together, experts came together, and from that, they were able to identify, I believe it was 73 different strategies. And so what's kind of cool is we have what the literature had, and now we have these experts coming together and kind of making a consensus on these strategies. Then we move forward in time. Oh, well, I guess it's kind of similar time, but in my mind, we're moving forward in time. And the use of, or the bottom left, the use of concept mapping, which is also shown, oopsies, sorry, I keep thinking that I'm on here, also shown on the right. I'm going to go big picture because that's how I am, because I think you can really get into the nitty gritty details. How I took this was, okay, so we have the 73 discrete strategies. We're going to also get, experts come together, and we're going to have them categorize them. So they did this kind of, in my mind, user-centered design task of sorting the different 73 strategies into what are similar. And again, just to make our brains be able to get at this better. What are kind of the bigger concepts that these fit into? And then they also had folks rate them, I believe it was on feasibility and importance. So they also used this mixed methods data of folks that are really overwhelmed with all the 73 strategies. Okay, what are those strategies that are highest in importance and highest in feasibility? So it's just, again, trying to help folks kind of take the immense amount of information that's out there and kind of categorize it to make it a bit easier. Oh, yeah, okay. Now it's Allison's turn.
Thanks, Ashley. So just to kind of summarize before we move forward, so the ERIC, the Expert Recommendations for Implementing Change, that came up with the 68 and then we came to 73 discrete strategies, was really like the first pass that anybody took at putting all of these potential implementation strategies together, right? And so this kind of serves as our menu as at least a starting point for selecting strategies. And then all of the different ways that they looked at categorizing them, I think, again, was just to serve to provide a little bit of a selection, a menu for people so that they could say, oh, I need some planning strategies or I need some financial strategies. And so that was, it's a lot of information about how we got to that, but just kind of think of that as your starting point as a menu of potential strategies that have been decided on by many experts in the field. Okay, so moving on from there, thank you. So now we want to get into, first step is then how do we pick the strategies that we want that are going to make the most sense for us and for our research study? And so from after finding that full list of the ERIC compilation, they actually then went back and were like, okay, we have these great strategies. What determinants do these address? They went again back to these experts. This is one of your optional readings for today. And they wanted to figure out, what do experts think are the best strategies to match with certain determinants that you've identified in your context? And so the C4 ERIC matching tool is one example. there are many limitations with this, but it is a really helpful place to start, especially for beginners starting to think about how do we put all of this together. So as a reminder, the CFR, the Consolidated Framework for Implementation Research, serves as a comprehensive framework for characterizing the determinants of implementation. And then the ERIC compilation is a whole bunch of implementation strategies. It's not really a theory or model or framework, it's just a list of strategies. And so this tool was developed to say, hey, you put in your determinants that you found with CFR, and then it spits out a bunch of potential strategies from the ERIC compilation that might match for you. And I'm going to give you an example of that on the next slide. But I also wanted to just point out this other article that Byron Powell again published about other methods to try to select and tailor your implementation strategies for your context. I'm not going to go into detail on each of these today, but this is, again, might be something that's helpful to come back to as a reference for later, where there's intervention mapping, there's concept mapping, conjoint analysis, and group model building, again, that are all just other ways to try to visualize and make sense of the relationships that you might have between your determinants and your strategies. So I think, yeah, next slide, please. Oh, sorry, back one, yeah, thanks. Okay, so this is one example of what might be spit out if you put your determinants into the CFR ERIC matching tool. So if you said that, unfortunately, right now there's low reflection and evaluation in my team that we're working on implementing this innovation with. And so what ERIC would give you is a couple of different levels of recommendations. The level 1 recommendations means that these are strategies that experts looked at and said, at least 50% of people said that, yes, this is a strategy that will address this determinant. And so the main two here, as you can see, are developing and implementing tools for quality monitoring. Like they really, if we're thinking about reflecting and evaluating, having some data to be able to do that with, like quality monitoring through audit and feedback methods, which is the second one listed there, is a really good starting point for then being able to overcome that barrier. The level 2 recommendations then that it's going to give you, it's okay, Ashley, are then our recommendations, or sorry, our matches for this determinant that were only endorsed by, I think it's 25 to 50% of people. So these are things that some experts were like, yeah, these might be helpful, but there wasn't as much consensus around, but they're helpful for you to consider, and it might make sense for you in your study, but maybe not for everybody. So again, this is a really helpful place to start. You can also see that these descriptions of the strategies are very general. It doesn't give you a lot of specifics. And so selecting them is step number 1, and that's a big step to take in and of itself. But then as we'll get into the next slide, it's really thinking about operationalizing and specifying. So next, please. So this is from, again, one of your required readings. Proctor et al. Put out these recommendations for how to actually specify and report on strategies. So if you think about this, again, compared to intervention research, when you put an intervention into place, and then when you publish your protocol paper or your outcomes paper, you have to really define very specifically what you did so that theoretically somebody could take that off the shelf and do the same thing and get the same outcomes. This is our attempt to do that same approach with our implementation strategies, where you provide enough information and enough details about what you did so that somebody else could theoretically use that same plan or adjust it as they need to. But also it's good for yourself to have a roadmap from your starting point so that you know what you're going to do moving forward. And you can, if you say you're going to do something monthly, that you actually follow through and do something monthly. So these points of specification, I'm going to go through an example on the next slide. So I'm just going to leave that there for now. So if you would please go to the next slide. Yes, thank you, Sarah. I completely agree with that. Okay, so I'm going to just walk through one example of specification from a study that Ashley and I worked on together, where we were trying to increase adherence to the guideline for blood pressure management in pediatrics. And so one thing that we wanted to do was to give folks proper training on blood pressure measurement, because there's so many times when people don't fully adhere to the guideline because there's so many steps to it. So this is, again, just a very simple example of training. So we define the actor as the person who is doing it, who's giving the training. Well, we had some champions put in place. The action specifying what they're doing is they were to conduct educational and hands-on sessions in order to train the clinical staff on how to do guideline adherent blood pressure measurement. The target of this action, so again, this is rarely going to be the participants themselves or the patient's population, because we're really focusing on the system and how this changes things in the system. So the target here is the clinical staff, because we want them to be doing accurate blood pressure readings. Temporality is when in the research study or the implementation plan are we thinking about doing this? Well, we wanted this to be something that was done throughout. We're not only doing a training at the very beginning, but something that was going to be ongoing. And then the dose we said we would do annually. We would make sure, because we know there's a lot of staff turnover, and so we're catching people at least on an annual basis, and then offering booster sessions as needed. And then the implementation outcome that we were hoping that this strategy in particular would address, right? We don't want to just do a strategy willy-nilly. We want to make sure that it's tied to something specific. And so this, we were hoping, was going to address our outcomes by increasing fidelity to the guideline for blood pressure management, increase adoption of adherence to this guideline among the clinical staff in particular, and then also sustainment of adhering to the guideline if folks are better trained. And the justification is because in the literature, we know that training is an often essential, if not sufficient, piece of pretty much any implementation plan that you're going to do, but it's particularly important for ongoing exposure, refreshing and maintaining skills, especially in the light of staff turnover. So hopefully that gives you a little bit of an idea of how we might specify this. And on the next slide, just very briefly, I want to point out that Dr. J.D. Smith, who is also the engineer along with colleagues behind the implementation research logic model that we're using, also has developed a system for tracking and specifying these strategies. I actually got to be a beta tester a week or so ago, and it's kind of fun, lots of point and click to really help you to keep track of all of these strategies, to specify them so that it's something that hopefully will be a little easier for reporting. But as you can see, it's a lot of work to go through each of these, but it's just so critical and so important in the same way we do for our interventions. Okay, thanks.
All right, so we always want to chat about centering equity, and specifically, obviously, within this week, thinking about implementation strategies. I think big picture wise, we should always be thinking, okay, what's reducing inequities in care? So really making that a really point whenever thinking, okay, what strategies are we going to use? How are we going to specify them? Making sure that we're always thinking how to reduce equities. Invest in identification, development, testing of strategies, especially strategies that may require additional components. So maybe not just taking strategies off the shelf, but really adapting them to think of advocacy, to think of cultural competence, just to really get at those factors of equity, and then engage multi-level partners, and then selection and specification of strategies, thoughtfully tailoring strategies to different contexts. So I would say, if you're like, oh, who's one of the people to look to, Anna Bauman is really fabulous in this field. So I took out 2 of her articles that I think we've mentioned before, but she's just really fabulous of thinking about equity and anti-racism, and just really putting that all together in implementation science. So I say definitely look to her or these articles to do so. Boop, boop, boop. No, I have one more slide on that. And then also, again, when thinking about adapting interventions and adapting strategies, I think it's really, what we know is really important to track what is being adapted, who's adapting it, when are they adapting it, how are they adapting it, and why is it being adapted? And then I think a really big thing to think about, especially with an equity lens, is evaluate that impact on different groups. As we know, interventions have different impacts on groups, so would strategies, even if it's at the system level. So yeah, and then require representation of community members from historically marginalized populations to inform the development of multi-level strategies and outcome measure. I think we can't stress this enough, just making sure we're representative within the folks that we work with, because I think us researchers, I won't get on my soapbox, but we do this top-down thing, and we don't need to do that. So we really need to, look to our community members, look to folks, and really gain their expertise. And then also, here's another article that that was pretty fabulous of equitable implementation at work. I think this was more kind of practical. So if you, want to pull that, it was also really wonderful as well. So I'm going to pass it to Allison for the case examples. Or wait.
All right. Yeah. So very briefly here, so this first case example is the screening and brief intervention for risky drinking in pediatric trauma centers. Next slide. I'm just going to kind of pop through these first ones just for your reminder. So we're going to be building our implementation research logic model. The innovation was defined as this screening and brief intervention, which was recommended by the American College of Surgeons. We identified our primary patient outcomes, and then we last week talked through the different barriers and facilitators that were identified with stakeholders and partners, and then also through the literature review. So then the next step was to select the implementation strategies that we're going to use. And so as you can see, actually those top three really defined the primary implementation approach of didactic training, performance feedback, and external coaching or facilitation. And the idea was, and the next slide, you can see how this is an example of starting to really specify how and when those different components happened at various stages. So not only during the implementation phase that we're thinking about using these strategies, but there's ways that we can use them in preparation for implementation, and also in thinking about how they are going to propose sustainment down the road. And then in the next slide, you can also see another beautiful way to look at this and being able to share, again, kind of exactly what you did. What were all of the components of your strategy? One really huge benefit of this approach is that they relied on a lot of widely available educational materials. So this is something that other teams could easily pick up and use and adopt for themselves in their own systems.
All right, and then to think about the second example that was really focused on planning for PrEP in local and health department STI clinics. And so just to go again over the implementation research logic model. So the innovation, or kind of, I guess you could think of the clinical intervention. So PrEP is that. And then what are our outcomes? And sorry, going over this quickly due to time, and we've gone over this a little bit, but happy in our breakout groups to get into any of these. For the clinical outcome, it was to prevent HIV infection. And then last week, went over, okay, what are some of those determinants, or what are some of those barriers or facilitators to the uptake in PrEP? And we were able to do it or chat across outer, inner, individual, and process. So for example, one would be financial access to PrEP, or there's just poor reimbursement. So then this week we have the strategies. All right, so an example would be, and I think we've talked about this a lot as a strategy, but didactic training for clinicians and clinic staff. And I think you could, if we're mapping, and we could talk about that more, mapping that onto, okay, lack of awareness and knowledge of PrEP. Oh, okay, let's do some didactic training. Or clinician willingness to provide PrEP. Maybe training will help with that willingness because they'll be more comfortable. No. And then I think we have one more slide before the announcements. Is it okay if I take this? Is that okay? Okay, and then Allison and I have a method, that we would love for you to look at and share. But what we found was really fun was that hadn't been done yet in the literature was working with our community partners in order to identify and prioritize or rate different strategies. So it was really, nerdy fun. It was really nerdy fun. We were able to do some user-centered design things to kind of also get or elicit the information other than interviews. And then, so that was the 2022. And then the 2023, Allison led this one. It's a really beautiful way to take, because what we did was it took a lot of time and a lot of sessions and just truncated it to make it more feasible. And then there's also Kelly Scott from CEDIS was part of another way to kind of think about how to tailor an implementation blueprint. So also check out that one. Oh, and then Allison already went through the matching tool. Boop. Can we do this one too? Okay. All right. And then in your breakout sessions, here's some questions that you can think through. And we'll put these in the chat because I can't ever remember, I don't know, what I had for breakfast this morning. So we'll put these in the chat, and then just a friendly reminder that we'll see you next time at March 6th. Yeah. Or do you want me to go through the questions? Sorry, I forgot.
Nope, that's good. Thanks, Ashley.
Good.
Wonderful. So feel free to pick among these questions. Of course, the small group leaders can also use their own, but there's some fabulous food for thought here for the small groups to pick upon in their discussions. In a few weeks, we will be talking about community engagement principles. So the question about where community engagement opportunities might fit with selecting and tailoring strategies is especially timely and might set us up nicely for that future conversation. And especially number 3, we always love to hear people reflect on the strategies you're using in your own work. And perhaps maybe you've done some of these strategies and didn't even realize you were doing them. So we'd love to hear your reflections. Our fabulous Emma Little, who usually does the group assignments, is doing manager training today. So Jordan will be putting us in the groups momentarily. So thank you, Jordan, so much for joining us and for leading this effort today. And we'll see you all in 2 weeks.